imagine a health issue that takes, well, on average, maybe 4 to 7 years, sometimes even longer, to actually pin down.
Hmm.
That's a really long time for your body to be changing without you knowing exactly why.
It really is.
So today, we're going to try and shine a light on exactly that kind of situation. We want to give you the insights you need to understand it better, maybe even help shorten that diagnostic maze, for yourself or perhaps someone you know.
Exactly. We're taking a deep dive into acromegaly today. It's certainly not a household name, but understanding it is really valuable.
Okay, so let's get right to it then. Acromegaly, what's the core definition we're working with?
Right. So in essence, acromegaly is a rare hormonal disorder. The key thing is an overproduction of growth hormone, GH.
Yeah, okay.
Think of it like a factory stuck in overdrive, just churning out way too much of this hormone. And in the vast majority of cases, we're talking over 95%, this GH surge comes from a non-cancerous tumor on the pituitary gland. It's called an adenoma.
Benign tumor, right?
Yes. Benign. Much less often you might see the excess GH being produced by, say, tumors elsewhere in the body, or even by tumors releasing another hormone, GHRH, which then tells the pituitary to make more GH.
Okay, so we've got this excess GH floating around. What does GH actually do? How does it work in the body?
That's where something called insulin-like growth factor 1, or IGF-1, comes in. It's a really key player.
IGF-1, got it.
You can think of GH as the messenger. It goes to the liver and basically tells it to ramp up production of IGF-1.
Ah, okay.
Then IGF-1 is the one that actually carries out most of GH's effects throughout the body.
Mm.
It influences growth, metabolism, all sorts of things.
So too much GH means too much IGF-1, and that's what drives the changes we see.
Exactly. That cascade is central to understanding acromegaly.
Now, you sometimes hear a similar sounding term, gigantism. Are they like the same thing or related?
Good question. They are related, yes, but they're distinct. The absolute critical difference is when the excess GH happens. Timing, exactly. Acromegaly develops after the growth plates in our bones have closed, which usually happens in adulthood. So instead of getting taller, you see this enlargement of tissues and organs. Things like your hands, feet, facial features tend to get bigger.
Right.
Gigantism, on the other hand, that happens when there's too much GH before those growth plates fuse, so during childhood or adolescence. And that's what leads to the significant increase in height.
Okay, that makes sense.
Yeah, here's a little memory tip that might help.
Yeah.
Think giant, for gigantism, obviously, height. And acro, which means extremities like hands and feet. For acromegaly, think enlargement of those areas.
That's actually really helpful. Giant for height, acro for extremities. Okay, now you mentioned this pituitary adenoma is the main culprit. Is there anything that makes someone more likely to, develop one?
Well, the primary trigger really is the development of that benign pituitary adenoma that's secreting excess GH. As we said, much less commonly, you might see GH produced by tumors elsewhere, maybe lungs, pancreas, ovaries even, or too much GHRH from tumors in the hypothalamus or other neuroendocrine tissues. But what's, both fascinating and frankly frustrating for diagnosis is how incredibly slowly these changes often happen.
Right, the insidious onset.
Exactly. That's a key reason why it takes so long to diagnose those 4 to 7 years or even longer that you mentioned right at the start.
Yeah, that delay really is striking. Are there genetic factors involved? Could it run in families?
Yes, in some cases it can. There are familial forms of acromegaly, and it can be associated with certain genetic syndromes.
Like what?
Things like multiple endocrine neoplasia type 1,
Yeah.
MEN1, you can maybe think of it as multiple endocrine neighbors, one-foot tumors popping up in different endocrine glands, including the pituitary.
Okay.
We also sometimes see it with McCune-Albright syndrome, Carney complex, and something called familial isolated pituitary adenoma, or FIPA.
FIPA.
Yeah. And interestingly, there's a specific gene mutation, the AIP gene, that's been found in about 15% of those FIPA cases and maybe 3% of sporadic, non-familial acromegaly.
And does that AIP mutation change things?
It often seems to. It's frequently associated with acromegaly starting at a younger age, and sometimes with larger tumors when it is diagnosed. So if you see acromegaly in someone quite young, it definitely makes you think about a possible genetic link.
So genetics can play a part, especially for younger people. But what about, day-to-day life, lifestyle, environment? Do those things increase the risk?
That's a really important point to clarify, actually, perhaps for your peace of mind listening.
Yeah.
The primary risk factor that's been identified is having that pituitary adenoma develop.
Yeah.
Currently, there just aren't any known associations or risk factors linked to lifestyle choices like diet or exercise or specific environmental exposures that have been directly shown to cause acromegaly.
Okay, so it really comes down to that tumor starting to overproduce GH. Once that excess GH is circulating, what actually happens inside the body? What's this sort of cascade of events?
Right. The sequence basically starts with that pituitary adenoma releasing too much GH.
Mm-hmm.
This then signals the liver, telling it to significantly ramp up its production of IGF-1.
Okay.
And it's really that elevated IGF-1 that acts as the main driver for most of the physical changes you see in acromegaly. It stimulates the growth of all sorts of tissues and organs throughout the body, and that leads to those characteristic features.
So like you said, GH turns on the tap, IGF-1 is the water causing the effects.
So that's a pretty good way to think about it, yeah.
We've already talked about gigantism as being different, but what other conditions might a doctor be thinking about if someone comes in with symptoms that could be acromegaly? What's on the differential diagnosis list?
Yeah, good point. Beyond gigantism, where, again, age of onset relative to growth plates is, key clinicians will also consider other pituitary issues, specifically pituitary hormone deficiencies.
Deficiencies. That seems odd if the problem is excess GH.
It does seem counterintuitive, doesn't it? But sometimes a larger pituitary tumor, even one making GH, can actually press on the rest of the pituitary gland and damage it, impairing the production of other essential pituitary hormones.
Ah, I see. The mass effect.
Exactly. But probably the most interesting and clinically important differential is something called pseudoacromegaly.
Pseudoacromegaly, so like a fake out.
Pretty much, yeah. Pseudoacromegaly refers to conditions where someone might develop physical features that look very much like acromegaly. You know, the enlarged hands and feet, the facial changes, but crucially, without the underlying hormonal problem of elevated GH or IGF-1.
Huh. So what causes that then?
Well, the classic examples include things like severe insulin resistance, where there's hyperinsulinemia, very high insulin levels.
Okay.
In that situation, the high insulin can sometimes mimic some of the growth-promoting effects of IGF-1. And perhaps surprisingly, treatment with minoxidil, a drug sometimes used for hair loss, has also been reported to cause a similar appearance in people.
Wow. Okay.
So it really drives home the point that looks can be deceiving, right? That's a crucial aha moment, I think. The physical appearance alone isn't enough. You absolutely need the hormone tests to confirm a true diagnosis of acromegaly.
That's a really critical distinction. Makes sense. Now, how common is this condition? Is acromegaly something doctors see often?
Well, in the UK, the estimate is around 60 cases per million people.
60 per million. Okay, so definitely rare.
Definitely considered rare, yes.
Yeah.
It seems to affect men and women pretty much equally, and the typical age when someone gets diagnosed is usually between 30 and 50.
And worldwide.
Looking more broadly, international data suggests the overall prevalence ranges from about 2.8 to maybe 13.7 cases per 100,000 people. The annual incidence, so new cases per year, is somewhere between 0.2 and 1.1 per 100,000.
Okay.
And again, that median age of diagnosis tends to be in the fifth decade, so the 40s. But sadly, because of that slow, insidious onset we keep mentioning, there's often that significant diagnostic delay, averaging around 4.5 to 5 years.
And the consequence of that delay?
A major consequence is that by the time acromegaly is diagnosed, most of the pituitary tumors are already macrodenomas, meaning they're larger than 1 centimeter.
Which I guess makes them harder to treat, potentially.
Essentially, yes.
Yeah.
Or more likely to cause other problems like visual field issues.
Right. That long delay really hammers home why recognizing the signs, even subtle ones, is so important. What are the key clinical features? What might make someone or their doctor start thinking about acromegaly?
The presentation can be quite varied, honestly, and it is often very gradual. But maybe we can categorize the key features to help remember them.
Good idea.
Okay, first let's think about physical changes. These are often the hallmarks. We're talking about that slow progressive enlargement of the hands and feet.
Right.
A really key question to ask, maybe if you're listening, is have you noticed your shoe size or ring size steadily increasing over the years in a way that doesn't seem related to just weight gain?
That's a very specific, practical question.
It is. Facial features also change. The nose might become broader, lips thicker, the jaw can become more prominent, what's called prognathism.
Okay, so those are the outward sort of visual cues. What other symptoms might someone experience?
Moving on to skin and hair, Excessive sweating, hyperhidrosis, and oily skin are really common complaints. Some women might also notice mild hirsutism, a bit more facial or body hair than usual.
Okay.
The voice can also change, gradually deepening over time due to laryngeal changes.
Right.
Sleep issues are also frequent, particularly obstructive sleep apnea or OSA. This is often linked to macroglossia, an enlargement of the tongue, which can obstruct the airway during sleep.
Makes sense.
A lot of people with acromegaly experience joint problems. Joint pain, arthralgia, that general feeling of stiffness and discomfort in the joints is very common.
Okay.
Then there's organ enlargement or visceral hypertrophy. This can affect internal organs like the heart, the thyroid gland, the liver, and spleen. And neurological symptoms can pop up too. These might be from the tumor itself pressing on things, or from nerve compression elsewhere. Carpal tunnel syndrome, that tingling and numbness in the hands and wrists, is a classic example related to soft tissue swelling.
Carpal tunnel. Okay. That's quite a diverse list already. Anything else?
Yes, definitely. We need to think about cardiac complications. Hypertension or high blood pressure is very common. Other heart problems like cardiomyopathy and arrhythmias can also occur.
Okay, serious stuff.
Very. Then there are metabolic changes. The development of type 2 diabetes or impaired glucose tolerance is quite frequent because GH counteracts insulin's effects.
Right.
Other potential issues include an increased risk of developing colonic polyps and also vertebral fractures. And of course, because the root cause is often that pituitary tumor, you can get pituitary tumor-related features. Headaches are common. Visual field defects, which might show up as blurry vision or losing your peripheral vision, can happen if the tumor presses on the optic nerves. And even galactorrhea, which is nipple discharge, can occur, often due to the tumor co-secreting prolactin or disrupting dopamine pathways.
So, a huge range of possible symptoms.
It really is. And it's vital to remember, again, the onset is usually gradual, that acral enlargement, the hands and feet, and the coarsening of facial features are often among the earliest signs, but they can be missed for years.
So if someone does present with some of these features and acromegaly is suspected, what investigations are typically done? How do you confirm it?
The diagnostic workup is quite logical, usually involving several steps. The first step is generally measuring IGF-1 levels in the blood.
Why IGF-1 first?
Because IGF-1 levels tend to be much more stable throughout the day compared to GH levels, which fluctuate a lot. And IGF-1 closely reflects the overall 24-hour GH production. So an elevated IGF-1 levels is a strong initial flag.
And if it's normal?
Importantly, a normal age and sex-matched IGF-1 level makes acromegaly very unlikely, generally helps to rule it out.
Okay, so IGF-1 is the first line screening. What if it is high?
If the IGF-1 is elevated, the next crucial step is usually what's called an oral glucose tolerance test, or OGTT, but specifically measuring GH response.
How does that work?
So you drink a sugary glucose solution. Normally, in someone without acromegaly, the rise in blood glucose should suppress GH secretion quite significantly.
Right.
However, in acromegaly, there's this paradoxical response. The GH levels either fail to suppress adequately below a certain threshold, or they might even paradoxically increase despite the high blood sugar.
Ah.
This abnormal, non-suppressible GH response during the OGTT is a key piece of evidence to confirm the diagnosis.
So blood tests are key. What about imaging and other tests?
Imaging is absolutely essential. A pituitary MRI scan, usually with contrast, is performed to visualize the pituitary gland. You're looking for that adenoma, assessing its size, its precise location, whether it's impinging on nearby structures like the optic chiasm.
Right, the optic nerves.
Exactly. And if the MRI shows the tumor is close to the optic chiasm, or sometimes routinely in pregnant women with a known macroadenoma, then visual field testing is necessary to formally assess if their peripheral vision is affected.
Makes sense. Any other hormone checks?
Yes, depending on the clinical picture and the MRI findings, doctors will often check levels of other pituitary hormones. Prolactin is commonly checked, as tumors can co-secrete it. They'll also assess the adrenal axis, cortisol, thyroid function, TSH, free T4, and gonadal hormones, LH, FSH, testosterone, estrogen. This is to check for any deficiencies caused by the tumor, as we discussed earlier.
Okay. And you mentioned thyroid and colon issues earlier. Do they get checked?
Good point. Given the slightly increased risk of thyroid nodules and potentially thyroid cancer, a thyroid ultrasound might be considered, especially if any nodules are felt on examination. And yes, because of the increased risk of colorectal adenomas and cancer, regular colonoscopy screening is generally recommended. The exact timing varies, but often starts around age 40 or sometimes earlier depending on guidelines and individual factors.
Okay. And the heart.
Absolutely critical. A thorough cardiac assessment is usually part of the baseline workup. This typically includes an electrocardiogram, ECG, and an echocardiogram to look for things like hypertension effects, valve issues, or that acromegalic cardiomyopathy.
Wow, so it's quite a comprehensive workup.
It needs to be. All these investigations together help not just confirm the diagnosis, but also assess the tumor's impact, check for associated conditions, and establish a baseline for monitoring treatment effectiveness over time.
So once that diagnosis is confirmed through these tests, what are the main goals and strategies for managing acromegaly?
The primary aims of management are really twofold. First, you want to alleviate the symptoms caused by the tumor mass itself, like headaches or vision problems, and also the symptoms caused by the excess hormones. And second, crucially, you want to normalize those hormone levels, specifically GH and IGF-1, as much as possible to prevent the long-term complications.
Okay. And how do you achieve that? What are the main treatment options?
The mainstays of treatment typically fall into three broad categories: surgery, radiation therapy, and medical therapy, or drugs. Often, a combination is needed.
Let's start with surgery. What does that usually look like?
Transsphenoidal surgery is very often the first-line treatment, especially for smaller, well-defined tumors.
Transsphenoidal. Through the nose.
Exactly. It's a minimally invasive approach where the surgeon accesses the pituitary gland through the sphenoid sinus, which is behind the nasal passages, to carefully remove the adenoma. They use either endoscopes or microscopes.
And how successful is it?
Success rates, in terms of achieving biochemical cure, vary quite a bit. They depend heavily on the surgeon's expertise, but also significantly on the size and evasiveness of the tumor. Smaller microadenomas have much higher cure rates than larger invasive macroadenomas. And even after seemingly successful surgery, some individuals might still have residual tumor tissue or ongoing hormonal excess, meaning they'll likely need additional or adjuvant medical therapy.
Okay. What about radiation therapy? When does that come into play?
Radiation therapy is typically reserved for specific situations. For example, if surgery hasn't been completely successful or isn't an option, or for tumors that are particularly large, aggressive, or invading surrounding structures, it can be effective but works slowly and carries risks like hypopituitarism down the line.
And you mentioned genetic counseling earlier.
Yes, that's particularly important for younger patients diagnosed with acromegaly, especially given those familial links and the AIP gene we talked about. It helps assess risks for other family members and informs future planning.
Makes sense. Okay, let's delve into the medications. What drugs are used to treat acromegaly?
There are essentially three main classes of medications. First, you have the somatostatin analogs, or SSAs.
SSAs, okay.
These drugs, like octreotide and lanreotide, are often the first-choice medical treatment if surgery isn't curative or possible. They work by mimicking our natural hormone somatostatin, which normally inhibits GH release from the pituitary.
And do they work well? Any downsides?
They can be very effective at lowering GH and IGF-1 levels and controlling symptoms in many patients. Potential side effects often involve the GI tract, things like abdominal discomfort, diarrhea, nausea, and they can also increase the risk of gallstones with long-term use.
Okay. What's the next class?
Next are the dopamine agonists, drugs like bromocriptine, cabergoline, and quinagalide. These can sometimes help lower GH levels, particularly if the tumor also co-secretes prolactin.
Are they as good as the SSAs?
Generally, they're considered less potent than SSAs, specifically for acromegaly GH control. Cabergoline might be an option, maybe even first line, for patients with only modestly elevated IGF-1 levels and milder symptoms. However, there's a known potential risk of cardiac valve fibrosis with higher doses or long-term use of cabergoline, so patients need careful cardiac monitoring.
Right, that's important to know. And the third class?
The third main option is pegozasomat, or PEG. This one works differently. It's a growth hormone receptor antagonist.
So it blocks GH from working?
Exactly. It prevents GH from binding to its receptors on cells, primarily in the liver. This stops the production of IGF-1. So while GH levels might remain high, IGF-1 levels can be effectively normalized in a high percentage of patients.
That sounds effective. Any watch-outs?
Yes, because it doesn't directly shrink the tumor, there's a theoretical concern about potential tumor growth, although it seems rare in practice. More commonly, patients need regular monitoring of their liver function tests, as liver enzyme elevations can sometimes occur.
Okay. Can these drugs be used together?
Yes, absolutely. Combination therapies are quite common, especially if a single medication, usually an SSA, isn't fully controlling the IGF-1 levels. Adding pegvisomant or cabergoline to an SSA is a frequent strategy to achieve better biochemical control.
What about pregnancy? Managing acromegaly then must be tricky.
It certainly requires careful consideration and specialist management. Generally, most medical therapies for acromegaly, like the SSAs and pegvisomant, are typically stopped during pregnancy due to limited safety data.
So what do you do?
Well, if treatment is deemed necessary during pregnancy, maybe for severe symptoms or tumor growth concerns, short-acting octreotide might be used cautiously. Cabergoline has a better safety profile established from its use in prolactinomas during pregnancy, but it's still used judiciously in acromegaly. It's also crucial to remember that active acromegaly itself during pregnancy carries risks, like a higher chance of gestational diabetes and hypertension.
So close monitoring is key.
Absolutely, by an endocrinologist experienced in this specific situation.
And I guess across all these different treatments, surgery, radiation, drugs, regular monitoring is just fundamental,
It's
right?
totally fundamental. Regular blood tests for GH and IGF-1, follow-up MRI scans, clinical assessments, they're all crucial to see how well the treatment is working, to adjust the plan if needed, and to watch for any tumor recurrence or the development of those complications we've talked about.
Looking at the bigger picture then, what's the general prognosis like for someone diagnosed with acromegaly?
Overall, the prognosis is actually generally good if it's diagnosed relatively early and managed effectively to control those hormone levels.
But if it's not,
If it's left untreated or poorly controlled for a long time, the prognosis is significantly poorer. Untreated acromegaly is associated with roughly a 2 to 3-fold increase in mortality, primarily due to those complications: hypertension, diabetes, cardiomyopathy, and the increased risk of certain cancers, particularly colorectal cancer.
are there factors that predict a worse outcome?
Yes, certain things are associated with a less favorable outcome. These include having very high GH levels at diagnosis, having a large or invasive tumor that's harder to control, already having hypertension, cardiovascular disease, or diabetes when diagnosed, and importantly, a long duration of symptoms before treatment starts. That diagnostic delay really matters.
Is there anything someone can do to prevent getting acromegaly in the first place?
Unfortunately, no. Currently, there are no known ways to prevent the development of the pituitary adenoma that usually causes acromegaly.
So it really comes back to early detection again.
Exactly. That just underscores the importance of recognizing those early, maybe subtle signs, seeking medical advice promptly, allowing for earlier diagnosis and treatment, which can definitely minimize the risk of those serious long-term complications.
You mentioned genetics earlier, specifically the AIP gene. Is screening done?
It's not routine for everyone, but genetic screening, particularly for that AIP mutation, has been suggested for certain populations, notably individuals of Irish descent. There's a specific founder mutation that has a higher prevalence in Northern Ireland and has been linked to familial cases of both acromegaly and gigantism there. Quite a specific geographical link.
Interesting detail. Okay, we've mentioned various complications throughout, but maybe we could just do a quick recap. What are the main long-term problems to be really aware of?
Yeah, definitely worth summarizing. So, key complications of untreated or poorly controlled acromegaly include hypertension. High blood pressure is very common, affecting maybe 40–60% of patients, and it really drives the risk of heart disease and stroke.
Okay.
Diabetes mellitus, again, very common due to the GH effects on glucose metabolism. Acromegalic arthropathy, that joint disease we mentioned, it can affect up to 70% of patients, involving cartilage overgrowth and bony changes, leading to significant pain and disability.
Right, the joint pain.
Obstructive sleep apnea, OSA, often due to that macroglossia and soft tissue swelling in the airway. It's common and contributes to daytime sleepiness and cardiovascular strain.
Mm-hmm.
An increased incidence of colonic polyps, particularly adenomas, and potentially colon adenocarcinoma, hence the need for screening. Also, an increased risk of nodular goiter and possibly thyroid cancer, leading to recommendations for thyroid checks. Sometimes, the treatment itself, especially surgery or radiation, can lead to hypopituitarism, where the pituitary gland underproduces other essential hormones. Hyperprolactinemia, high prolactin, can occur either from the tumor itself or stalk effect, causing issues like irregular periods or low libido. And we shouldn't forget the psychological effects, the changes in appearance, chronic symptoms. They can significantly impact self-esteem, leading to social withdrawal, anxiety, and depression.
Yeah, the quality of life impact must be huge.
It really can be. All these factors contribute to a significantly impaired quality of life if the condition isn't well managed.
That's a sobering list, but really important to understand. Okay, to sort of wrap up our deep dive here, What would you say are the absolute must-remember points about acromegaly? The key takeaway.
I think three main things stand out. First, remember, acromegaly is fundamentally about excess growth hormone, GH, usually from a pituitary adenoma, leading to high IGF-1 levels. And it's this hormonal excess that drives the condition.
GH and IGF-1, got it.
Second, the onset is insidious. Symptoms develop slowly over years. This often leads to a significant delay in diagnosis.
The crucial delay.
Yes. And third, recognizing the characteristic physical changes, especially enlarged hands, feet, and facial features, alongside other systemic symptoms like sweating, joint pain, sleep apnea, is absolutely critical for triggering investigation and achieving earlier diagnosis and treatment, which dramatically improves the long-term outlook.
Those seem like really solid takeaways. Thinking about that long diagnostic delay really poses a question, doesn't it? Considering how long it takes, what more could potentially be done to raise awareness of those early, sometimes really subtle signs of acromegaly, both for individuals, noticing changes in themselves, and also for healthcare professionals who might be the first point of contact.
That's a really profound question, actually, because shortening that diagnostic window feels like it could make such a massive difference to people's lives and outcomes.
It really does. Addressing that through, I suppose, ongoing education and just broader awareness seems key.
I agree completely. It's vital work.
Absolutely. Well, if you listening want to reinforce your understanding of acromegaly or perhaps explore other medical topics as part of your revision or learning, make sure you check out passthemsra.com and also freemsra.com.
Yeah, great resources there.
They really are fantastic resources packed with high-yield information to support your learning journey. So thank you for joining us for this deep dive today.
Thanks for tuning in.
We really appreciate you investing your time with us to learn about this important, though rare, condition.